Hi, everybody. Welcome to the Pediatric Readiness Recognition Programs Collaborative. We are on session 6, and we will move forward. We've got the funding acknowledgement. As a reminder, this is a joint initiative between the Pediatric Pandemic Network and the EMSC Innovation and Improvement Center, which is supported in part by the Health Resources and Services Administration. However, just know that the contents of this session are those of the authors and not necessarily represented the future official views of or an endorsement by HRSA, HHS, or the U.S. government. And well, housekeeping items. We go through these, but again, we can't thank you enough for joining. You are here. You're doing the work amongst your busy schedule. So thank you very much for joining us. We will be recording this session and providing the link later on if you need to share it with your team or if for those who can't join us today. If you would like to speak up, ask questions, chime in, go ahead and raise your hand with the little icon down at the bottom. You can, it's reactions at the toolbar at the bottom of your screen. You can raise your hand or you can just come off mute. And as usual, today's session will be very interactive as we move forward with the minimum criteria consensus. Next slide. So our goal for today is to discuss and edit the proposed criteria in the minimum criteria consensus process and prepare for round 3. So if we go to the next slide, our PRRPC session agenda, we decided a few sessions ago that we would split it up and we would work on the minimum criteria for the ED, Pediatric Readiness Recognition Programs, in the beginning, and then we would spend an equal part for the minimum criteria for the pre-hospital Pediatric Readiness Recognition Programs. Instead of having that middle 30 minutes to talk, we decided to take this entire time today and split it up 45 minutes to discuss ED and pre-hospital and finish up round 2. And so that we can prepare for round 3 and get that next survey out to you. So as a reminder, this consensus activity, here is our outline of that. We've gone through round 1 where we voted to keep or toss some of the proposed criteria, and we took what made it through round 1, and we sent out the survey for both ED and pre-hospital and asked you to rank 1 through 5 based on evidence, feasibility, and importance of that criteria, what you feel should be kept as a recommended minimum criteria for a recognition program. We have been discussing those round 2 results, and we are in the middle of that analysis and results, analysis of the results and the feedback. And so hopefully we will be able to finish that discussion today and move on to our re-ranking in round 3 and come to that final consensus. So as we move forward to round 3, we're going to jump ahead instead of moving this to the end of the session. We want to go ahead and talk to you about the next steps. So the round 3 survey is ready to go. We're hoping to get that out to you early tomorrow. And some of the things on that we heard loud and clear and wanted to let you know that the evidence portion of that ranking wasn't your favorite thing. So we have taken that off. So you will now, for round 3, be ranking 1 through 5 on evidence and importance. Importance and feasibility. So is the criteria important to have as a minimum criteria for recognition program? And is it feasible to have that as a minimum criteria for your recognition program? So there will not be any more ranking on evidence. We will, just as in round 2, we'll take the average score per state for the final. So you can still share the survey with your team and your key players as you need to. But if we get more than one survey back from a state, we'll take all those surveys from that specific state and compile that into one score, average that out, and that will be considered for that one state. We have created a handout with the consensus process outlined so that you can share that with your team and your key players if you need to. It also has some information on round 3 and how we'll go about doing this. So the due date, I would like to talk to you about that. We have March 15th here. That is 4 weeks from tomorrow. However, we want to make sure that that is doable for you. So I'd like to hear from you, either again, chat or come off mute. Is 4 weeks enough time to complete both the ED and the pre-hospital minimum criteria surveys? Given that our next PRRPC session is going to be March 21st. They are, Kasey, they're 2 separate forms, right? The ED and the pre-hospital, it's 2 separate surveys, or are they all in one?
Correct. It'll be 2.
Two surveys.
Similar to how it was last time. Nicolina feels like 4 weeks should be fine. Right. See some thumbs up. Perfect.
How many criteria in each, Kasey?
My 22 and 19.
22 and 19. So you'll be ranking 22 for ED and 19 criteria for pre-hospital, and you'll be ranking those based on importance and feasibility. So it looks like we're getting a lot of good to go on 4 weeks.
Thank you so much.
And would you like to come off mute and ask your question?
How broad is the outreach? I mean, I assume it's within states, and, you know, I'm just trying to figure out what the full expectation is.
Mm-hmm. So each state, we'd like to hear from each state, at least one survey per each state. Some states, the survey is sent to the program managers for those state partnership program managers. And so ideally, each program manager would submit a survey, but sometimes we've heard that they have teams, they have state advisory councils, they have fans that are included in their teams, and their directors, others involved. And so if needed, they can also take the survey and be invited, but that's as needed. There's no requirement around that.
Okay, I was just trying to figure out if it's going to be something that, you know, if you need broader input, then it's going to take longer. if it's something that the state manager can do, maybe with some input of the TAC or, technical advisory committees or others, that's fine. I just want to know what the expectation is. One last question, if you don't mind. Do you want a single answer, or I assume you'd want to know who they are from what state, or are you going to collate responses, let's just say from our EMS for Children Technical Advisory Committee from California? We each fill it out and send it to you and you collate that. I'm just trying to figure out that expectation as well.
No, this is a fantastic question. So what happens is the surveys are set up in REDCap. And so if you, and you being anybody, if anybody from that state, we'll use California since you use that. If anybody from California completed survey 2, round 2, they would have completed first a demographic form that stated their name and their state. And then they were taken to the ED ranking survey. So if they completed round 2, that demographic survey and round 2 survey, then this round 3 survey, they will automatically be taken to the round 3 survey. They don't have to complete the demographic, and we'll have that information. If, say, you had someone who wasn't available, maybe they were out on maternity leave or they're new, that did not complete round 2, they will need to complete that demographic survey to be taken to round 3. So yes, to answer your question, we will have the name and the state that they're from.
Got it. Thank you.
Great questions. Okay, so it looks like 4 weeks. So we'll go with March 15th. If we could have all those completed, and then during that next session on March 21st, we will discuss the final minimum criteria for both ED and pre-hospital. So if we can go to the next slide, let's think about what, when we rank, if you'll remember, we rank 1 to 5, and we take the averages and we look at the scores for each of those. When we come back in March, we want to talk about what the final recommended minimum criteria, what you came to consensus for this starting point for a recognition program to have as minimum criteria. So we need to think about what score, and they're to the 10ths. And so we've got 4.1, 4.5. What score will allow or will be that breaking point for that recommended minimum criteria? And then on top of that, if, say, we have a criteria that didn't meet that score, say, I'm going to throw out 4.4. Maybe we think about everything 4.4 to 5 is our minimum criteria. That's what we came to consensus for our minimum criteria. What happens to the rest of the criteria 4.3 and below? We've got some ideas, but we want to hear from you about that, about the criteria that, because these are criteria that have been suggested, they've been used in other programs. So we don't want to just throw those out and not consider them. Several of you will still use those for your recognition programs. So we can think about having them as optional. Maybe you have recommended minimum criteria and then a stretch goal and then optional criteria to be considered. Do we have anybody who has input or thoughts on the minimum score? Or how you would like to look at the final results? I saw Carrie first with the hand raise.
Sorry, I couldn't figure out hand raise versus clap. So with stuff that's below, say 4.4, if that's our cutoff and stuff like that, my main concern, quite honestly, is I realize this is probably more of a comment for the next session. Is I'm from New Mexico. We have a lot of folks that are going to be struggling just to meet the minimum criteria, much less anything that's below our cutoff criteria. And I think a look forward, try to shoot for these goals are going to be good. But even in the hospital settings, I've got some really small hospitals in some outlying areas that just dealing with the challenges now, they do a lot, but I'm still afraid that most of my hospitals are going to come up short on the 4.4. Is there a way to bring in the stuff that's below 4.4 to kind of boost a score to meet some sort of recognition, honorable mention, something like that? My concern is some of the hard work that some of the smaller outlying hospitals are doing are not going to be recognized. And if we're not able to give them something to shoot for, then the next year when I go out there to Las Vegas, New Mexico, population 1,400, they're not even going to try it because they came up short the last time and they have nothing to shoot for. So just a concern of mine. Thanks.
Points. Dwayne?
So I view, and this is just me and my vision, I view the minimum criteria as the lowest recognized level, but we're including a participating level or an entry level per se, so that people can step in and get into the program. But I don't know that they're going to be recognized, but they're part of the program and they're engaged with the program resources, and all they're going to do is get better based on that engagement. So, my opinion would be that the minimum criteria is the lowest level of recognition, with additional levels, if that's the case, shooting at a little bit more comprehensive look at each of the categories. And, and I think that's a lot of our concern. And just speaking with some of my colleagues is, if we go and get to shoot too high for the stars, we're going to lose engagement, lose participation. And the bottom line is everybody is going to lose, including the patients that we're trying to have these hospitals ready for. So I just see it at the minimum criteria is that initial level of accreditation standard. I weigh this out with my steering committee and get their feedback, and that's what I've been doing with the surveys, and that's what I'll be doing with the results. And so if they agree with that, then that's where we'll go. But that's just kind of my viewpoint.
Thank you. Nicolina?
Sorry, I was desperately trying to get off mute there. For some reason, it wasn't working. So Colorado has their program already up and running, and we did this process in-house with our steering committee. And I very much hear what Carrie and Dwayne are saying, because one of the standards that came from our steering committee's work was, much like Carrie was saying, not all hospitals have access to the same tools. And so much like Dwayne was saying, we created ours with the minimum standards. And then, so we have 2 tiers in our program. The very interesting thing I will tell you is I have more rural hospitals who are interested in our pediatric readiness program than urban. And once they started the work, they found it to be very attainable, and they have gone for our higher tier. And some of their pediatric readiness scores have more than doubled, and some of them are coming out in 198 on that scale when they do the reassessment. So I think what Dwayne is saying is really hitting it on the head, thinking of some of these as the minimum requirements. But I would also tell you, it's been really surprising here in Colorado how intensely our rural facilities have adopted this and met the challenge. It has taken them about a year start to finish, and some of them have continued on with the work. But I think it's attainable. And so acknowledging what both Carrie and Dwayne said, I think is really important.
Thank you. And Mark?
Thank you. I would also concur with what Nicolina and Dwayne have said in our rural aspects is making this obtainable. Half of my challenge is just to get them engaged. And when I can get them engaged, I can build off of that. And if it becomes too difficult to obtain anything, they'll give up, and then I've lost them as an audience or an opportunity for the future. I know the question, and I think I understand this, so forgive me if I messed it up, but in terms of what should be the minimum criteria and the score, I think that was your main question. I think when I consider that, is it's difficult to say what is the minimum score for it to be considered a minimum criteria, because I don't know how many that affects. So if the minimum score is 4.5 and all of the criteria are 4.5, that's no longer minimum criteria, that's all criteria. So I think I look at the overall scoring of it and how that breaks down over all the criteria that are being evaluated, and how do you find a balance of what are obtainable and what's reasonable and not reflective of one, for example, a large institution that has a lot more resources than a smaller hospital that's struggling to get by. We want to engage them and build with them and create steps to improvement, and not necessarily walk in and go, oh, too bad, you're out. And I think that would be challenging. Thank you.
And so, Kasey, if you will skip the next slide, because I think that is, or go to the next slide and
Would you like to see overall scores?
yes. So skip that next slide. So this is what I was getting at. So if we look at these scores, these are from round 2, and this is ED. We can see that the overall average, these are ranked from highest to lowest. So if we took 4.4, we're looking at really those top like 8 or 9. But if we look over, we wouldn't have both weighing children in kilograms only and weighing and recording children's in kilogram only. We'd have to combine those in some way, and there's several like that. And then another thing I want to point out here is if you look at when we think about, we're looking at the overall average, and we have those ranked from highest to lowest. But if you look at to the far right at the range, this is the range. So you're looking at who the average max, everybody, so every criteria, somebody scored this a 5. So a 5 on importance, a 5 on feasibility, and a 5 on evidence. And then the minimum is the average of minimum score. And if you look at the range of that you can see the higher the range, the bigger the difference in the ranking. So if you look at least one PEC, that had a higher overall average. If we go with that 4.4 score, 4.5, that at least one PEC would make it to the minimum criteria, but the range is very large. And so one state might say, no, that's not going to work. And another one says, yes, absolutely. So those are just things that we need to consider when we re-rank. And then also when we look at these. I think at this point we can move on and finish the discussion for the round 2, unless someone has something to add more to how to look at this.
Oh, Dwayne has his hand raised.
I see it now.
Just real quick, I was going to type, but I think these are all grouped, and I consider the checklist focus areas as a component to weigh them. So if if I've got something in a focus area that jumps out over other considerations, that would be my minimum criteria for that focus area, the 7 focus areas. And that's just the way I'm looking at it. But I just think that might be another way of assessing where the minimum might fall based on those 7 different areas that are part of the checklist, that are part of the consensus document.
Point.
See Cynthia's comment in the chat. Eleni, can you share the link to that document with her, please? If you would like the overall ranking, just reach out to Eleni in the chat to make sure you get the link. All right, so go ahead and start discussing these. Again, this is the opportunity to make any edits to the criteria, really voice your opinions on whether you feel like it should be included, or speaking against why maybe shouldn't be included as minimum recommended criteria. And find my notes of the ones we discussed last time. So last time we did start with weighing children in kilograms only as one of the criteria we discussed. So real briefly, if there's anything else to add, go ahead and come off mute and share if there is. If not, we'll move forward. We also discussed weighing and recording children's weights in kilograms last time. Right. This is one that is ranked highly, has an overall average score of 4.6. And again, you can see those rankings based on evidence, importance, and feasibility. And then at the bottom, we have the range, or how far away are we from consensus. The smaller the number, the closer we are to consensus. So this one is access to pediatric crash carts in the emergency department. And then you can see some of the comments we received, feeling it's important, easily feasible to have equipment. Then on the other side of that, the smaller hospitals have challenges in obtaining, as well as using pediatric specific equipment prior to expiration due to the low volume. Just some of the comments. Again, this is a chance to really speak to having it included as minimum criteria. With that in mind, if we were considering maybe 4.4 as that threshold to be included as the minimum recommended criteria, this would be included. Any comments or edits, recommendations? Like, have a thumbs up. Good minimum criteria being used. I don't know, Mark, if you can come off mute maybe and share your question with the group.
Sure. I like the idea of access to pediatric emergency equipment. I struggle with the specificity of a crash cart because some hospitals are small enough that they have all the equipment bedside or built into the treatment areas. And so does that mean they don't meet that minimum criteria because they don't have a cart? And I just, maybe it's getting too far into the weeds, but it just jumps out at me. Thank you.
Yeah. Other thoughts on maybe making an edit to that to access to, I don't know what the phrase would be, but we can make an edit to that.
I would see many also have a crash bag. So I think at least expanding it to include that would be helpful.
Okay. Any other edits to that one? Great point, Dwayne. Right. And then we did discuss last time at least one PEC. Again, this is a 4.5. So if the rankings didn't change much in the next round, this could be recommended as a minimum criteria or a starting point. But again, this item does have our largest range in that threshold of the higher scores. So we're pretty far apart on feeling that it's important to be considered. Something to be considering whenever you're ranking this in the next round. All right, so this one we didn't get to last time. It's include pediatrics and policies and procedures. We had a bit of a spread in between our importance and our feasibility score. Average was a 4.6 for importance and a 4.3 for feasibility. Overall average being a 4.4. The range was a 3.2. Again, this potentially could be in that threshold of being included as minimum criteria. So some of the comments. Help focus care pediatrics, provide best treatments, a lot of free resources. Concerned that all facilities will be able to comply if it's a requirement. What other thoughts do we have on this item? Or any recommendations to edits? Anyone like to speak in favor of this one? Looks like Pat has her hand raised.
Yeah, in my experience, you know, depending on the setting, you know, sometimes hospitals or organizations opt to include, you know, special populations as part of a core policy or procedure versus a dedicated policy and procedure. So I think, you know, it's possible to meet that criteria as long as it's including children in their policies and procedures for specific, you know, areas. They may not, you know, because, you know, policies and procedures have a lot of care and feeding. And so to create a whole set of policies and procedures for children, you know, may be perceived as, you know, not as efficient as just including them in, you know, making sure that that population is included in an appropriate policy and procedure. Just wanted to raise that variability.
Thank you. Marianne?
Yeah, I was just agreeing with Pat, but there are some that are going to be very specific to children, so we may want to be cognizant of that. We do know that almost all the hospitals end up having child abuse policies, but that would be one that I would see that needs to be separate. So we may, I think to say that every policy has to be separate, I think is way overreaching, and that we should really specify the ones that are specific to children and otherwise integrated into their policies, but some kind of call out within those policies makes sense to me that address the specific needs of children. Thanks.
Seeing this one sort of as in addition to maybe current policies and inclusion of children. And then I think later on, we have a couple criteria that are the specific policies related to child maltreatment. And so those would be separate categories. But again, this with maybe that 4.4 threshold would be included or recommended as minimum criteria. Right.
Yeah, but Marianne, I could see, a hospital having a generic policy on domestic abuse and have specifics for vulnerable populations because, of, to meet those requirements. So I think making sure that it's inclusive is important, and that the key elements are and that the key issues addressing children are appropriately addressed in and
You lost Pat. Any
Yeah, it does in part make sense to me, but there are some very specific things that are needed. So as long as, there's enough content, it's really a judgment call. So I like the idea that they may be integrated. Maybe the best language is they may be integrated, but must include specific guidance relative to care of children.
Thank you. Right. And then this sort of moves into the more specific categories of the policies. So these are, again, the same average score, 4.4. So depending on that threshold, you had to include pediatrics in policies. The next one is pediatric specific triage policies. Similar scores on importance and feasibility. A ranges of 3 on this one. Not as far apart, but still pretty spread out in our responses. Similar comments to this one. Me.
Just one comment to share with this one in particular is that ENA has officially endorsed ESI as the triage tool to be used in the pediatric population and also more broadly. And since ENA staffs all emergency departments, or ENA members do across the country, it seems like this would be an easy one to request.
Hey, Kate, also, I know that in California, that some of the counties, including my former county, established a common triage for both pre-hospital and hospital as well, not to replace the ESI, but to support the integration in terms of triage. How would we address that? Or that would seem to also qualify.
Yeah, this doesn't specify ESI, but I think the lack of a triage policy makes it difficult to identify a critically ill or injured child.
Any other comments or questions about this criteria? Edits? things to consider when we vote on the third round. Next, we have all recommended equipment and supplies being immediately available. So again, our importance score of a 4.5, feasibility was a 4.2, came to be an average of 4.4, which theoretically could be in that threshold of minimum criteria. And then similar comments to those that we received related to the emergency equipment being available or the crash cart. Great question. How would we like to define immediately? What are some thoughts on maybe some edits to that criteria or how that might be better suited to fit with recognition programs within the ED? Any other thoughts on that one?
Yeah, I think words like immediately are subjective and it, within the, within the emergency department or, rapidly accessible to staff, those kinds of things might be more appropriate.
And then Jessica, do you want to come off mute and share your question?
Yeah, I was just clarifying, is the recommended equipment, is that the recommended equipment list from the NPRP list, or are we talking like more specifically crash cart type equipment?
I don't know, Kate, if you want to share your thoughts on that criteria, or maybe someone who's implemented this criteria in the recognition program would like to speak to it.
I'll just say that the median score on the equipment domain within the NPRP assessment was 100%. And we've seen ongoing availability or improvements in the availability of pediatric specific equipment. The most critical still being airway equipment and, gaps related to that. I don't think it's an unreasonable ask to sites. I think if a site or a state were concerned about this, you could focus on the highest priority items related to pediatric airway and resuscitation. But all of the equipment recommendations within the pediatric readiness guidelines are intended to be used in the acute resuscitation of a critically ill or injured child. So there's nothing that was really intended to be excessive in terms of something unnecessary. But in terms of availability, just to speak to that too, the goal was that you didn't have to call the pharmacy or the surgical suites to have equipment come to the ED, but as was stated, readily available within the emergency department was the intent.
Marianne?
I agree with everything Kate said. The other thing is that when we look at cost, it is incredibly low. So it seems to me that we really cost is not a huge issue here for most hospitals. And so when you look at the overall cost of readiness, it's really in staffing. And so my feeling is everybody should have, and we're not saying how many they have, they just need to staff up to it. So for a critical access hospital that sees very few children, having everything available, at least one is good, and a process to replenish is probably more important for them. But in larger hospitals, it's really operational costs. That's to Kate's point, the median was 100, meaning they have everything. So I think we're saying, I don't think this is a barrier, but it seems reasonable to include.
Yeah. Right. So our next criteria was daily method to verify the proper location of pediatric equipment and supplies. This has an overall average score of 4.3. Might be below that threshold we were discussing as being included in minimum criteria. But I did have an average importance score of 4.4, feasibility of 4.3. Any comments on this one or things to consider before we move forward with the next round? And then we have ED disaster plan must include pediatric considerations. Score of 4.3 overall, importance of a 4.5, feasibility of 4.2. Disaster plans. Any comments or thoughts about the inclusion of disaster plans as minimum criteria?
This is Cindy from Maryland, and I have lost my ability to raise a hand. So can I just comment?
Yeah, absolutely.
I'm not sure what happened. I think as I've listened to others, and as I've just come off of our HPP coalition meetings for the last 3 days, I think it depends on how a plan is defined. As we look at what Asper Tracy has funded across all of the states, being part of a regional response plan and having knowing what you can do for children, where children can go. If a plan is a few pages and it's being actively aware of what your pediatric annex is, I think that's doable across all over the country, including rural access and freestanding. If a plan is a doctoral dissertation and includes absolutely everything available, I think that's way too much. So it's a matter of language, and it may even be better to say that the ED participates in the disaster planning and includes their pediatric capabilities in that. But I am one known for too many words, so I will be quiet.
Thank you. Mark, if you want to come off mute and share your question.
I think it's more of just trying to clarify when we say a disaster plan, are we thinking about an emergency department that has a disaster within its own emergency department, hospital-wide, system-wide, county, state? Is it all of those things? Because when we start looking at regional or state disaster plan, it isn't an ED disaster plan anymore. It's a state disaster plan or county disaster plan. So does that impact things and what we're looking at for criteria?
The intent of this was within the institution as opposed to a regional or statewide plan. It's that which is within the control of the hospital or the emergency department. And as Marianne put in the comments, there are some specific guidance within the Pediatric Readiness Joint Policy Statement regarding specific components of this. But because the ED is the front door to most disasters, whether they be, man-made or environmental or chronic pandemics, the recommendation is that there be pediatric specific considerations that would impact the care of children, even within that ED.
And I certainly get that. I think about some of the example in Maine, the during COVID, some of the disaster plan for if pediatric patients were inundating an ER, the plan was to refer to the state plan. And it was simply that. Is that something that we're looking for it to say, or is that so nuanced that it's beyond the capacity of this discussion right now?
A great question. I defer to your colleagues on that.
Maybe Evelyn, if you'd like to share a little bit about what you're asking of hospitals in relation to this criteria.
Sure. As I just outlined there, we actually ask hospitals to have a pediatric surge plan. And within that plan, they have to outline or bullet how they would handle a surge of pediatric patients. So where would they accommodate those pediatric patients? Do they have an overflow area? Who would they call in? What kind of capabilities do they have or can access to be able to handle those needs? And in some cases, it is reaching out to their region and to the state to assist with resources. But in the end, if there's a multi-vehicle crash that's right outside their door that brings in 20 significantly injured pediatric patients, they need to have some type of a plan in place to be able to at least draw from that and identify how they're going to meet those needs.
Yeah. And Dwayne?
So I would echo that. I think there's some confusion in many of our heads about the generalized term disaster plan and the application of the disaster resources and implementing things in a surge or a response. I posed this question to our federal partners on the EMS side of it to try and get some clarity. And then if I look at it from the healthcare hospital side, internal versus external disasters have totally different implications and responses within the facility. So I think some clarity on the term would help understand the importance and relevance of it. And is this a surge plan to, respond to an external incident involving pediatric patients? Maybe, a definition or something along those lines would help guide people's thought process.
Kathleen.
Thank you. I think one of the things I'm just wondering about with this, and to get to your point, Dwayne, is that the MPRP checklist, has certain items kind of related to this. And we used those individual items to kind of define what this means in our pediatric readiness recognition program for Colorado. And it's, around the areas of medications and a surge plan. And what we found is in Colorado, a lot of hospitals said, well, we have a disaster plan, but it was really about how does the hospital respond when the water goes out or the electricity goes out. And it wasn't really focused on patient care as much as like infrastructure of the actual facility. So I think this speaks to kind of clinical care. And we also, our hospital preparedness program here in Colorado, along with our HCCs, had used the AAP Pediatric Annex to kind of help define some of those things as well. So I think there's a lot of ways to skin this cat, but I would personally, we reverted to the MPRP checklist to kind of help with our definitions in Colorado.
A lot of great discussion. Appreciate everybody's comments and input. So moving down our list, we had pediatric competencies, evaluations for nurses. So had an average score of 4.3, feasibility was a 4.5, or I'm sorry, feasibility was a 4 and importance of a 4.5. Our range was still a 3. This one had some good comments. So noting that we know that regular skills training and evaluation is shown to improve provider confidence, but also the lack of financial or personnel resources and difficulty having all nurses comply with this standard. Any comments or feelings towards the inclusion of competencies as minimum criteria? And in this case, related specifically to nursing. Right. Again, if there's any comments or things you want to be considered by the group when we move forward with that third round, feel free to jump in and let us know. We then had family-centered care policies in the same sort of block of scores, 4.3. Still high scores for importance, 4.4, feasibility of a 4.1. This is in that policy category, but more specifically calling out family-centered care. All right, next we had pediatric evidence-based pathways and or decision support. Again, the average score of 4.3. So below that threshold we had discussed earlier of being included as minimum recommended criteria. Average importance, 4.4. Feasibility was a 4.1. Any comments about that one or feedback, things to consider? This one's another policy, ranked at 4.2 overall. So again, in that policy category, maybe something that can be considered in that including pediatrics in the policies. Well, this one's calling them out specifically. Moving along, we have pediatric competency evaluations requiring pediatric skill practice. This one had an average score of 4.2, ranked highly for importance. I would say this had our greatest span between importance and feasibility, a feasibility of a 3.9. If there's any comments, feel free to step in. I'm gonna go through these here. Can get to the pre-hospital criteria as well. Requiring critical or commonly missing pediatric equipment. This is ranked with a 4.2. Importance was a 4.4, feasibility of 4.1. And this would be below that threshold we discussed for the minimum criteria. So keep that in mind. This one had our large range, again, a range of 4. So meaning we had folks voting for a 5, folks voting for a 1. So we're not quite a consensus of where we believe that should be. So just something to keep in mind whenever you're voting again during the third round. Right, interfacility transfer guidelines. Again, this one had a large range, a range of 4, overall average of 4.2. Any comments about, or anyone want to speak to maybe the importance of interfacility transfer guidelines? I'll make sure I'm giving space to have discussion if you would like to. Right, pediatric mental health policy. Quite a few policies out there, so.
Are we done talking about IFT?
I can go back if there's any.
The only thing I want to mention is that IFT transferred are very much influenced by payers and systems. So and those things influence where the kids go more than a lot of other things.
The mental health, and then our QI plan has an overall average of 4.2, importance of a 4.4, and a feasibility of a 4. Any comments about QI plans? Okay, so we had competencies for nurse staff members earlier, and this is for all staff. It's ranked lower with an average of a 4. This one had some general comments of wanting to have defined staff. If anyone wants to speak to that one or feels strongly that it should be included as minimum criteria. And we had that range of a 4. So we had folks who felt very strongly about it, and then those who felt on the opposite end. Eric?
Yeah, my only concern with this is that recently I've had some discussions with physicians, and they said that requiring competency evaluations for all staff, I would assume would include physicians. And depending on who they are, they said that we're never going to be able to get them to be a part of competencies. So that would be my only concern.
Mark. Thank you, Eric.
I ran into a new issue with some of this, working with some new hospitals looking for recognition, and that it becomes a union issue for nursing and is beyond the capacity of me, or in some cases the hospital, to address or edit this without opening up union contracts. So that's a consideration as well.
All things to consider when we move into that next round of voting. So thank you.
May I ask a question real quick?
Mhm.
Sorry, in the next round of voting, is there a refinement of the language? For example, to Mark's point about unions, could it be like, should have minimum annual competency skills evaluations to has opportunities for annual, skills evaluation, you know what I'm saying? Or opportunities for annual training or maintenance of skills. That there's a program in place that may not be mandated, but that is held. Would that be like something that might kind of get at that better a little bit? Because I know no doubt that, Mark, you're not alone in Maine with looking at nursing union rules and issues like that.
Like Jennifer might also be experiencing something similar. I don't know if you maybe want to speak to how you're trying to address that.
Oh, Kasey, were you calling on me?
Yeah, you can share if you'd like to.
Sorry about that. Yeah, I think this is of all the list, as we sort of map out our Maryland criteria, we've kind of come to the conclusion that really our minimum is going to pretty much match most of the existing NPRP checklist, and feels doable. And this is the one that gives me the most heartburn, is trying to convince physicians to participate in skills checks and competencies the way that is very well integrated into nursing culture. So we're trying to repackage this into pediatric specific continuing education units for physicians, similar to the way that for trauma or burn centers, physicians have to have trauma specific con ed, and or creating like simulation and education modules that we can put out to our PECs or our nurse and physician champions to run as teamwork exercises in emergency departments, and counting participation in those scenarios as a competency or a skills check for the physicians in an emergency department. But it's progress.
Thank you for sharing, Pat.
Yeah, it really depends on the leadership in the various institutions. But one strategy would be to try and engage the physicians in participating as, instructors, and to get that level of recognition. I've also heard physicians say, if they were given even a title, or to recognize their level of participation in, Peds Ready and that type of thing, that those acknowledgements are meaningful, in some settings.
Thank you. I think I saw.
I put into the chat what our Colorado criteria are. We we just recommend maintenance of board certification for people boarded in pediatric emergency medicine or emergency medicine. However, physicians boarded in family medicine require some PALS or APLS or something like that. That's our criteria.
Yeah, I agree with what you're saying there, Kathleen. I think those criteria are very, that feels like something very feasible. It also feels to me, when I, play devil's advocate with myself, that somebody who's board certified in emergency medicine 30 years ago and isn't paying attention to, current pediatric standards of care, are they legitimately still competent or not?
Yeah, I think 100% understand that. I'll take it back to like how these criteria and then operationalizing it in your state. We do a site visit, and that's where we kind of get into the weeds on things with sites, so that's how we've operationalized. Like, we have some minimum criteria, and then we use the site visit to really verify some of those key aspects, which are more holistic than just checking that box.
Yeah, I agree. The board certification is kind of the achievable piece. And I'm hoping that in this recognition process, we can figure out how to maybe raise the bar just a little bit without the physicians mutinying against it. So it's tricky.
A lot of great comments in the chat. I appreciate everyone's input. Right, so the next three we've discussed sort of similar criteria. This is the QI plan that includes pediatric specific indicators and tracking performance. We had previously discussed having a QI plan. So this is building on that previous criteria. You'll see the lower average score. This one is interfacility transfer agreements. We have previously discussed intertransfer guidelines. And then building on disaster plans. Any of the criteria discussed today that anyone wants to call out or comment on additionally, let us know. If not, I feel like we might be prepared for the third round. All right. Sorry, we are running a few minutes behind today, but we are excited to get to the pre-hospital recognition programs criteria. So appreciate you all sticking through that with us. Again, we've ranked criteria by overall average from highest to lowest. You can see the maximum score, the minimum score, and then the range of those two, which helps us see how close we are to consensus. The lower the range, the closer we are to consensus. So previously we had discussed some of this criteria. We'll breeze through those. All right. So this is one that's ranked very highly, a 4.6. So as we discussed at the beginning of today's session, that's sort of in that range that would be considered recommended minimum criteria. And this is one of the items we discussed last month. We also discussed weight estimation systems. We did not get to this one last month, but it is ranked highly with an overall average of 4.6, including pediatrics and policies and procedures regarding the reporting of child maltreatment. Again, this is for pre-hospital criteria. Had an average importance score of 4.7 and a feasibility of 4.5. So I think majority of the comments related to these criteria were related to the fact that they might already be considered in state level legislation and sort of how that might play a role in which criteria will be recommended as minimum recognition criteria. Any feedback or thoughts on the inclusion of this criteria? Some thoughts on the wording of this one? Child maltreatment, pediatric. I can see the redundancy. Any recommendations on how we could rephrase that?
Domestic abuse policies that are required by Joint Commission, okay, include pediatric, so I would, you could restate it that way, or you could leave it the other, but I think we need to give some, the domestic abuse policies have stronger teeth in them, actually, in terms of policies and procedure through Joint Commission, in terms of what the hospitals have to do. And if we can get children appropriately addressed as part of those policies, then they will show up in Joint Commission reviews more often, is my thinking.
I think, Pat, are you extending kind of what Joint Commission does out to the pre-hospitals?
Oh, I'm
Because
sorry. Thinking more hospitals. My apologies.
Oh, no,
Yeah,
no
we made a
worries.
quick transition. I appreciate that.
Sorry, guys.
I think that I was going to say the criteria can just say have a policy and procedure regarding the reporting of child maltreatment, period. It doesn't say include pediatrics in. That would solve that problem.
Thank you. All right.
Yeah, I think that's simpler. It's easier to understand as well.
Okay. All right. This one. So ranked highly, 4.5 average. Its criteria is pre-hospital personnel can locate pediatric specific equipment. Had a high importance score of 4.7 and a feasibility of 4.3. So locating the equipment, a lot of great comments about that one. Again, some concerns about it being included in state level recommendations. So. I'm sorry, I missed that chat or this comment. David, is that in reference to this this criteria? Language needing to be cleaner. You're still with us, David. If you wouldn't mind coming off mute and sharing your concerns with them.
That comment popped up on your previous one.
Okay.
Yeah.
Appreciate that. Any concerns about the inclusion of being able to locate pediatric equipment within minimum criteria for pre-hospital agencies? So including pediatrics and policies and procedures regarding the use of trauma triage destination protocols. A lot of comments about this one. It had a score of 4.4. So again, it could be considered within that threshold of being included for minimum criteria. Importance of 4.4, feasibility of 4.4. Again, if we make note of this one's range, it does have a range of 4. So we're pretty spread out on our thoughts about this. Folks considering it very important with ranking it as a 5, and those also ranking it with a 1. So something to keep in mind when we vote in that next round. I think some of the concerns were about how this might affect non-transporting agencies. I don't know if someone wants to, I don't know, Dwayne, if you want to expand on that a little bit more or speak to how that might influence its inclusion or need to be excluded.
So these policies and procedures regarding destination are part of statewide protocols in Pennsylvania.
Mm-hmm.
They don't apply to a non-transporting agency. The treatment does, but the destination doesn't. Therefore, it's a gray area in that it's in the statewide policies and procedures at their scope, but it doesn't apply to them. And I'd hate to require something that doesn't apply to them, but it doesn't have an exception, and then somebody start getting in deep into it and start saying, well, it says you have to have this, and they don't have it. Therefore, some simple language, scope. I think the term before was talked about scope dependent, or, licensure level dependent, or something like that, so that it identifies the issue for the appropriate level of service being administered.
Adding, I think Mark recommended for transporting services as a clarifier. I saw thumbs up from Sam. Any other recommendations to make that more?
Can I just clarify too, because I want to make sure I'm reading it right, because I remember this conversation being kind of nuanced. So in addition to the clarification, I really like what Mark wrote for transporting services, right? Because the way it's currently written, when I see triage destination protocol, so this takes me down two ways of understanding it. One, using triage, like trauma triage for a patient, and then two, understanding destination for transport. Those are kind of two topics, both of which are probably pretty heavily considered by the state's EMS protocols for many of our states who have those, as well as situationally for the places that already exist. So I just need a little bit more clarity if anyone can provide it. Like, is this saying that they need to have a policy for where the trauma patient's going to go, or how to triage them, or both?
Good question.
So I would perhaps have Kate speak up about this, but I think that what this is saying is that, there's the CDC and now ACS field trauma triage guidelines, and that is your physiologic and your anatomic criteria driving whether you're going to go to the highest level trauma center possible versus, your local hospital that may not be a designated trauma center. So it is about using certain criteria to determine destination. And the shift and change in that is that it used to have a mechanism criteria. That mechanism is a consideration, but not an official criteria. And pediatrics has historically been in physiology and anatomy, but it's been difficult because a lot of EMS agencies haven't been getting accurate or even obtaining some of the physiologic criteria to make that determination. That is kind of what this is about, that there's a national guideline and then adoption of those national guidelines in your local protocols.
And I don't even think it specifically says the new CDC field triage guidelines, or those would be the ideal to provide
Right.
to as agency if they had no means of deciding where to take children in the setting of trauma. But the goal is that this is within the available resources. We're not saying that they should, be required to fly children in certain situations. It's just the idea that they have some way of guiding their providers in the event that they're managing a pediatric trauma.
So, okay, yeah, thank you for some of that clarity, because I think that was some of the ambiguity for me in reading it, especially because right now a lot of what's occurring is kind of provider best judgment, and this is actually a topic that we're discussing robustly here. So I just don't know how to clarify some of those things in such a question so that every state would understand that without being able to have this dialogue.
Would it be fair to simplify this criteria a little bit and just say include pediatrics in trauma triage destination protocols for transporting services?
Yes.
I think, Mark, you have your hand raised.
Just again, a clarification around this. For Maine, we have statewide protocols, and if a service adopted local protocols different than the state, they would be in front of our investigatory board and be in a lot of hot water. We have statewide trauma programs and statewide trauma triage criteria that we utilize. So is the intent of this that if a service said, well, we use Maine State established protocols, they would meet that criteria? Or is this that they have to go above and beyond that, which is going to create a lot of legal issues in our state?
Mark, is pediatrics addressed in
Yes.
protocol? Then
Yes.
same deal in Maryland. I feel like this is done and done.
So if they, so if we went in and looked at a service and they said, yeah, we use the statewide protocols, and the statewide protocols have that in there. Whereas I realize other states would have to work with a local entity or a county or a regional area based on the nuances, but many of us have statewide protocols. Would that be check, you're done? And that is the intent of this, or is it to alter it? I'm just trying to wrap my head around that.
What are the thoughts of the group?
This is Cindy, and I think if we take what both Dr. Anders and Mark said, and I don't know how to change this language, but the detail of the explanation is going to be what's important, both on a survey as well as in criteria language, because it could be local protocol, regional protocol, or state protocol, whichever is applicable in your jurisdiction, agency, EMS operational program. Here in the DMV, which we call DC, Maryland, and Virginia, we have all three. Maryland is state, but the other surrounding areas are not.
I think one thing just to consider, and we're at the top of the hour of people's time, but is these criteria are, I imagine, would be kind of your template, and then you crosswalk these criteria to what works in your state. Is that a fair understanding of that's the way I've kind of seen this process? I feel like I cut everybody off with that statement. Sorry.
I agree with what you're saying, Kathleen. I mean, this is just intended to be some kind of template, and it seems like state, regional, or local recommendation or protocol would suffice.
Yeah, I would agree. There's variability. It's hard for me to even think that there is a transporting agency without a protocol that includes a trauma triage protocol that doesn't include children. I mean, I can't even imagine that. It's just the variation that is at play.
Appreciate great discussion. I move forward with the next criteria. So this was pre-hospital personnel physically demonstrate the correct use of pediatric specific equipment. This was ranked highly, 4.4, importance score of 4.6, and a feasibility of 4.1. So this was the physically demonstrating the skill. Any comments or things to consider as we move forward to the next round of voting for this one? Eric, your hand raised.
Yeah, just to clarify, I mean, it says pediatric specific equipment. What equipment? Is it the agency's choice?
What are thoughts on how to address that? Or what have you done maybe if you do implement this criteria?
I mean, from our perspective in New Jersey, in our program, if somebody has the policy or the process in place to demonstrate the correct use of pediatric equipment, we don't really require them to do 5 specific pieces. It's if you have a program using simulators or you have a program using specific equipment, then we give them credit.
Any other thoughts on that or share your experiences? Marks, this should be a sampling. Yes, to Sam's question, maybe you want to come off mute and share that one.
I think it just honestly goes back to the conversation you guys were just having, and I was typing it at the same time. I guess for me, so if we're setting forth a minimum item here, and it's physically demonstration of correct use of PEDS equipment, it just honestly, those are the questions I would be asking if I was the one who's supposed to verify this. I would be like, okay, what satisfies physically demonstrating it? Is a simulation? Is this in education? Is it once a year? Is it once per license cycle? Like, how am I supposed to verify this one? Because that's kind of what I think of too on the other side for how do we set minimum? How do we verify it? And what is the equipment that's being demonstrated?
Thank you. And Mark, you have your hand raised.
I was just going to add to what Sam said, and agree, but also when we look at current national EMS education standards, we've moved away from rote demonstration of equipment, and I support putting your hands on equipment and using it. I've been an instructor a long time and way on board with this. However, our national education standards step away from just demonstrate how to use a device and more of how do you integrate that into a skills scenario and a comprehensive patient care demonstration. So should it be reflective of that, of managing all steps of care, let alone, and not just, do you know how to hold a laryngoscope correctly? And I don't know the answer to that. I just raise it as a question.
All right, well, we are at the top of the hour, so we didn't quite make it through all the pre-hospital criteria, but we have had a great conversation today, so I look forward to continuing with that. I think we have 9 more to go, if I'm right. So I think we'll have to put a pin in the discussion for today. Would still like to send you all the 3rd round for the ED criteria and then pick up with this discussion next month. And then we'd be prepared to send out the 3rd round of the pre-hospital criteria. So appreciate you all being flexible. I hope that's feel like a good direction to go. If there's any comments or additional thoughts on how we might proceed, feel free to let us know. You can share it now or send us an email. But if you're all agreeable, I would still like to send you the 3rd round for the ED criteria and get that process moving. We'll finish the conversation for pre-hospital criteria next month. And then be able to start potentially reviewing the 3rd round for ED criteria. Any concerns about that plan moving forward? Again, appreciate your flexibility and great discussion today. Really appreciated that. Thank you all and have a great rest of your day, and we'll see you next month. We're looking out for some emails from us tomorrow.